Hello, good evening all. Warm welcome to all the participants who have just logged in for the scientific session. Today, we are going to hear from an eminent speaker, a wonderful topic, when to suspect rheumatological problems in pediatric office practice. And Dr. Virudhunagar, President of Savagasi IMA and convener of Virudhunagar District Pediatric Club, warmly welcome all of you. The pediatricians from Virudhunagar District, nearby Madurai District, as well as from rest of Tamil Nadu, as well as members of the Savagasi IMA. It's indeed a privilege to have Dr. Sathish Kumar here. I know Dr. Sathish from 1995 when he was doing house agency at Virudhunagar Medical College. Such a nice man. And he did his DCH and the MD Pediatrics at the CMC, and subsequently he joined as a teaching faculty in CMC, and now he is occupying the post of Professor of Pediatrics at the Department of Childhood. And he underwent pediatric rheumatology training at Sick Kids Hospital in Toronto, Canada, and he did his fellowship there. And as my knowledge goes, he is the only pediatric rheumatologist in Tamil Nadu. And indeed, and he is a regular speaker in various academic fora. Even a few weeks before, he spoke on DAP platform too. And I warm welcome to all the doctors who have just joined. And I request Dr. Sathish Kumar to proceed with this topic, when to suspect pediatric rheumatological problems in office practice. Over to Dr. Sathish Kumar, please.
Thank you. Good evening, friends. Thank you, Dr. Venkat, Dr. Nikhil, Dr. Shanmana, for inviting me to deliver this talk. As Venkat said, I'm not the only pediatric rheumatologist. There are a few more pediatric rheumatologists in Tamil Nadu, especially in Chennai. So what Dr. Venkat requested me to talk is when to suspect rheumatological disorders in our office practice. Okay, so what is the agenda for tonight? And okay, so I'm a big fan of CSK. If today CSK would have played, I would not have this talk today. But anyway, today Delhi Capitals and Sunrisers are going to play. What I thought was, I'm going to talk to you for the next 40 minutes on common clinical scenarios in office practice and common laboratory clues in the office practice regarding to rheumatological cases, and how will you correlate clinical and laboratory clues in your practice. Okay, so pediatric rheumatology during our medical training, during our MBBS days or in the postgraduate days, it was what I felt was they didn't teach much in our medical school. The reasons may be a lot, like it is rare, it is difficult to diagnose, it is boring, it is very expensive treatment because lifelong treatment, and the treatment is very expensive, and it is a chronic disease, and it is also felt that the outcome is very poor. So this is not given much important during the medical schools. And the last thing is, it is not kept in the exam for your long case or short case. So none of us, including me, give importance to pediatric rheumatology during your medical training. But when it comes to the practice, that's what going to help you, or we are going to see a lot of patients with pediatric rheumatic conditions in your day-to-day practice. So very important thing in the pediatric rheumatology is pattern recognition, because rheumatology is a one specialty which is more and more clinical, and it involves various organs in the body. So as a nephrologist, it's very easy to see 2 kidneys. As a cardiologist, it's very easy to see 4 chambers. But if you want to be a rheumatologist, you should be first of all, you should be a very good clinician. You should look into all the organs, because most of our disease in rheumatic disease are multi-organ involvement. Okay, so when I put this picture for my talk last week, the people who are there in 1980s and 1990s, will easily identify this pattern. No need to show the full pattern. If I show this negative, everybody can understand this is from Basha movie. I was so happy to see this movie again in Sun TV today afternoon. So if your mind does not know, is that the pattern which shows it is a rheumatic disease, your eyes, when you're busy practice, will not see a clinical pattern in rheumatic diseases. So pattern recognition is very, very important in pediatric rheumatology. So what are common symptoms of children who presents to a general practice OPD? When you're sitting in your OPD, what are cases you see with rheumatic disease complaints? So they can come with joint pain. So joint pain can be acute. The joint pain sometimes will be chronic. Sometimes there is a mimicry of joint pain. They all present with joint pain, but is not definitely a rheumatic diseases. They can come to your OPD. Second thing is the fever, either a short duration fever or prolonged fever, and they come to the OPD when you suspect rheumatic diseases. Skin, especially with the rash, different types of rash are seen in different pediatric rheumatological conditions. And the last one is what are the laboratory clues to suspect rheumatic diseases. So we will go into one by one and see what is the pattern and how can you recognize to make a diagnosis in your OPD. Okay, so we'll start with the case. So it's a 10-year-old child who presented with OPD with a history of joint pain for 2 weeks duration. So this is a complaint. So what are the questions as a pediatrician or a physician you should ask to make a clinical diagnosis? So whatever I'm going to talk today is all about clinical diagnosis, because the clinical medicine is the one which is very, very important to diagnose pediatric rheumatic diseases. And investigations are done just to confirm the disease, not for diagnose the disease. So you have to ask these 5 questions. If you ask these 5 questions and answer all the questions, 99% of the time you will be right in making a clinical diagnosis of pediatric rheumatic diseases. So first question, is it arthralgia or arthritis? So we all know that arthralgia means joint pain, arthritis means inflammation. So all the arthralgia is not arthritis. So we all taught in pathology about this 5 signs of cardinal signs of inflammation, like your heat, redness, swelling, pain, loss of function. So if somebody has joint swelling, it is definitely arthritis. Or if they have 2 of the following, like limited range of motion, tenderness, joint warm, and pain with motion. So if these things are there, you will take it that as arthritis. Okay, second question, where is the pain originating from? So you all know that in a joint, normal joint, you have muscles, bursa, bone, synovium, membrane, synovial fluid, cartilage. So we have a group, and tendons also gets attached. So where is the pain really originating? Is it coming from the joint, or is it coming from the muscle, or it is coming from the bone? So that's another important question. So how do you know that it is articular? So if there is a swelling on the joint line and the joint line tenderness, limited range of motion, both on active and passive movement, causes pain, and presence of instability, locking, crepitus, or deformities. If it is a non-articular, you will have the pain more away from the joint capsule. There may be a focal swelling or point tenderness. We'll come to that. This is very, very important, because in a mimic of somebody, something called venous malformation around the knee joint, they will have focal swelling little away from the joint line. They mostly have pain on the passive movement only. There won't be any absence of instability, crepitus, or deformity. So next question. So first question, is it arthralgia, arthritis? If it is arthritis, where it is starting from? Then the third question is inflammatory or non-inflammatory. So how do you know that? If it is inflammatory or infection, they'll have pain, warmth, erythema, swelling, and tenderness. So in this picture, you can see that right knee is normal. You can see that there is nice hollow around the knee, and the left knee, as the arrow indicates, it has got effusion, swelling is there. Presence of morning stiffness or gelling. So that is, again, says it is inflammatory. Usually non-inflammatory, lax, swelling, or warm. Symptoms, systemic symptoms like fever, fatigue, and weight loss will be there. And in non-inflammatory, there will be no systemic features. If you do investigations, ESR, CRP, and thrombocytosis will be there in his inflammatory. In non-inflammatory conditions, we'll have normal ESR and CRP. So when you look into the causes of joint pain, it is huge. If you look into anything, any disease can cause joint pain as a manifestation. So you take it from infectious or post-infectious, connective tissue disorders, including vasculitis, sorry, hematological disorders, including malignancy, non-inflammatory conditions, some joint miscellaneous conditions, all can present with joint pain. So how are you going to differentiate all those things? So inflammatory, I told you, we talked about swelling, redness, warmth, and early morning stiffness. So non-inflammatory conditions, there is few non-inflammatory conditions. You take it trauma or any fractures, which can present joint pain and joint swelling if they have a fusion. Growing pains, as a pediatrician, we all know about growing pain. Hypermobility syndrome, there are a group of conditions, and there are some orthopedic conditions sometimes land in the general pediatric OPD, especially slipped capital femoral epiphysis or leg cavity-Perthes disease. Again, when somebody comes with joint pain, the history is very, very important because that's going to give a clue towards what is the diagnosis. So if somebody has got joint pain for a few hours to days, 1 or 2 days, we call anything less than 6 weeks as acute, more than 6 weeks as chronic. Few days to few hours, you suspect septic arthritis. Somebody comes with fever, swelling, first thing should be septic arthritis. Always remember to ask history for trauma if somebody comes with the acute pain, and coagulopathies, especially hemophilia. 2 years old child walking and running had a swelling on the left knee, you should suspect hemophilia. If it is little going prolonged, few days, then you should suspect either is viral, post-viral, or post-vaccinational. You also think of acute rheumatic fever. We'll come into each one details. Vasculitis and non-inflammatory conditions sometimes can go for a long time, especially growing pain or systemic onset JA. If it is more than 6 weeks, you think of JA, juvenile idiopathic arthritis, TB, fungus, brucella, all can present with arthritis like a chronic arthritis. So whenever child comes with joint pain, you should also think of extra articular features, especially that will give a clue to a diagnosis. Somebody along with the joint pain and joint swelling, if they have fever, weight loss, rash, oral ulcers, alopecia, think of lupus. If they have muscle weakness and classical rash, dermatomyositis. If they have classical, again, rash, palpable purpuric rash, abdominal pain, and hematuria, you should suspect HSP. If they have dysentery, diarrhea, weight loss, abdominal pain, you should suspect inflammatory bowel disease. If they have uveitis, you think of juvenile idiopathic arthritis, Behçet's or sarcoidosis, urethritis. Previously, we call Rita syndrome or reactive arthritis. Somebody has got weight loss or night pain, you think of malignancy. So we'll go back to, so now we have a knowledge about what are the etiology, what are the history you should ask. So first is arthralgia or arthritis. Second question is it articular or periarticular? Third thing is it inflammatory or non-inflammatory? Then you should ask about systemic features. And depending on the time of the presentation, the duration of symptoms, you should make a clinical diagnosis. So here is a 13-year-old boy who has got irritability and refusal to move the left leg for 3 days. He's only 1-year-old child. Cough and cold was there for 2 weeks back. No history of trauma. It's just a 3 days duration, so acute. And this 13-month-old child, very difficult for the parents to see the swelling. They all come with the refusal to walk or irritability. When we examined, the child was very febrile, 103, was apprehensive, lying in the left knee, held in the flexed position, and the hips are externally rotated. There's got pain and decreased range of motion of the left hip, and left knee is swollen and warm, as you see in the clinical picture. So it is an acute history. There is child is febrile, and there is a red, warm, tender joint. So this should be, your diagnosis should be septic arthritis, nothing else, because the child is very sick, apprehensive, and touching the joint, child has got severe pain. So this one don't diagnose as reactive arthritis and wait, because septic arthritis is a medical emergency. We have to refer to the orthopedician for early incision and drainage of the joint, followed by antibiotics. So here is another 4-year-old child. He has got URI for 2 days, some low-grade fever URI. He comes to your OPD, he walks, but he has got a limp. When you examine, the child is febrile, drags the left leg, and his left hip movements are restricted. but you didn't see any swelling or any redness, nothing was there. And you did a parameters, inflammatory parameters. CRP is mildly high, ESR is 35, which is slightly increased. So the clinical diagnosis you should suspect is transient synovitis of the hip. You can see the difference between the previous child and this child. This child is relatively afebrile. The child walks and with the limp and mildly elevated ESR and CRP. So remember that transient synovitis. Again, if you have any doubt about septic arthritis, you should refer to the orthopedic colleagues. And usually WBC is normal, ESR, CRP is mildly elevated. If you do ultrasound, there may be a mild joint effusion. So there is a criteria, something called Koch's criteria, where we can help. It's a clinical plus laboratory. You can make a diagnosis of septic arthritis if you suspect. So what is the criteria says? It's got 4 parameters: fever more than 38.5, inability to bear weight, ESR is more than 40, white cell count is more than 12,000. If you see here, if the child has got any of these 3, the probability of septic arthritis is very high, 93%. But if all the 4 are there, febrile, not inability to bear weight, high ESR, and white cell counts are really high, then the probability of septic arthritis is very, very high. If it is not there, you can diagnose transient synovitis. It is self-limiting condition. You need some bed rest and anti-inflammatory. If you suspect septic arthritis, definitely you have to go for joint aspiration. And prognosis is usually very good in transient synovitis of the hip. Another group. So here is a 9 years little older child, low-grade fever for 2 days with upper respiratory infection 3 weeks ago. She has come with a history of joint pain and swelling involving large joints. According to the history, but when you examine, the child was afebrile, but the child had polyarthritis involving large and small joints. Here you can see ESR and CRP is high, ASO is 720. So we always suspect somebody has got typical sore throat, URA symptoms for 3 weeks, followed by polyarthritis. Our first diagnosis are always acute rheumatic fever. We all are very good in diagnosing acute rheumatic fever. But remember, there is an entity called post-streptococcal reactive arthritis. How do you differentiate? Both will have high ASO, high inflammatory markers. How do you differentiate these 2 conditions? It's very easy. You can see that usually PSRA is usually happens in little older children. Okay, but you all know that acute rheumatic fever can happen anytime from 5 to 15 years. The streptococcal, the disease onset from post-streptococcal infection is 7 to 10 days. Acute rheumatic fever is usually classical, 21 days. The joint involvement is very, very important. You should ask the history. So here is additive and persistent. That means large and small joint can get involved and axial joints can get involved. But typical acute rheumatic fever, we all know that it is migratory, it is transient, and mainly large joints. Small joints will never get involved. So the child I showed you has got small joint involvement also. And again, very important thing, as we said, we always teach our medical students, acute rheumatic fever, dramatic response to NSAIDs. Here, there is a response is very, very poor. Again, you can see carditis also can be seen in some few cases of post-streptococcal reactive arthritis. Antibiotic prophylaxis if there is echocardiogram is abnormal. Otherwise, we treat with NSAIDs for 4 to 6 weeks, but PSRA needs little more time to settle than compared to our acute rheumatic fever because there is no dramatic response to your NSAIDs. So another child. So this is a 5 years old child who has come with a history of fever for 2 weeks and he has got arthritis pain over large and small joints. He has got night pain. He is sitting in the night holding his shin and calf muscle pain. He is crying with pain on touching the joints. So here is very, very important clue. Here also child comes, don't diagnose child has got reactive arthritis because there is a warning signs or the red flags like night pain, crying with pain on touching joints. So usually what you see here, this picture, the first picture on the left side shows the arthritis of the ankle joints. But here usually in the acute leukemia, it is periarticular. So that's why they don't have a typical swelling of the joints. They have pain all over because of the malignant cells deposited below the periosteum. So they all have severe pain, night pain. So this child, your diagnosis should be acute leukemia and refer to the, don't wait for the counts to come. If the counts can be normal during the acute episode of acute leukemia, if the counts normal, does not rule out acute leukemia. So most of the time we have problems in diagnosing or dilemmas in diagnosing, and especially when child has got systemic arthritis and leukemia. And systemic arthritis, you have less painful arthritis. Here is very severe bone pain, night pain, rash. The classical systemic rash comes along with fever in 90% of the people. In leukemia, the rash is due to thrombocytopenia. So it will not go away. It will be there always. The fever may be low grade in leukemia. And systemic arthritis will have very high white cell count and platelets. Here in leukemia, the counts can be low or normal. Sometimes you may have blast or may not have blast. Absence of blast does not rule out leukemia. Only the symptoms, excruciating pain, symptoms out of proportion to the signs, you should suspect leukemia. Okay, so we'll come to the next group. So so far we talked about septic arthritis, we talked about transient synovitis, we talked about malignancy, how the joint pains and the arthritis looks in malignancy. Here we have a 3-year-old child. She has got 3 months history of swollen, painful right knee only. No preceding fever, no preceding history of trauma. It is going for 3 months. She continues to walk, but her parents notice she is less active, especially in the morning. 3-year-old children does not say they have early morning stiffness. They prefer to lie down in the bed for a long time. Once the time goes by, they get up and walk. When we examine, the right child is afebrile, the right knee, there is effusion with limited range of motion, and a warm knee without a erythema. She can walk and run, but she has got a right-sided limp. So diagnosis for this child should be juvenile idiopathic arthritis. It is not juvenile rheumatoid arthritis. It is juvenile idiopathic arthritis. So how will you, there is a classification criteria. It's again, remember that it is not diagnostic criteria. It is a classification criteria. Any child who has got arthritis less than 16 years, arthritis in at least one joint, duration of arthritis more than 6 weeks, and you should exclude other causes of arthritis. So you cannot write diagnosis of malignancy and juvenile idiopathic arthritis. You should exclude all the causes of arthritis. And you also should know that juvenile idiopathic arthritis is not one disease. There are 7 different subgroups were included under them, under the one umbrella, like oligoarthritis, polyarthritis, which is rheumatoid factor positive, negative, enthesitis related arthritis, psoriatic arthritis, systemic onset JA. So remember that is a classification criteria. It's not for diagnosis. So it is again going to go by your history, clinical examination, and what pattern of involvement the child has got. So anybody less than 16 years, more than 6 weeks of persistent arthritis, you should suspect juvenile idiopathic arthritis. So pauci-articular or oligo-articular, I'm just showing the picture. Any small girl, especially 2 to 4, 5 years old children, they come with asymmetrical large joint arthritis. So they can have asymmetrical, only large joints. Small joints are very, very rarely involved. They come with swelling, early morning stiffness, and they will have something called asymptomatic uveitis. We'll come to that. So we have to send it for eye checkup. They will not have any symptoms. They will have acute and they will have chronic anterior asymptomatic uveitis. So the next group is girl. Again, is a adolescent girl. You can see that symmetrical polyarthritis of large and small joints, shoulders, elbows, wrist, small joints, knees, ankles, hip, all can get involved. So this is the adolescent girl who presents with polyarthritis. You should suspect rheumatoid factor positive polyarticular juvenile idiopathic arthritis. Another one is polyarthritis, but rheumatoid factor negative. So here also they will have large and small joint, again symmetrical. This can involve small children and adolescent people also. So this is more common in girls. So this is a systemic type. There is no specific difference between the sex. Both boys and girls get involved. So they have very high grade fever. They have classical rash. They have large and small joint arthritis. They have this. They can have serositis. They can have hepatomegaly, splenomegaly, lymphadenopathy. They can have pericardial effusion, pleural effusion. So that is your classical systemic arthritis. The last group is your adolescent boy. So you can see here is adolescent boy more than 8 years old. So this is your enthesitis related arthritis or HLA-B27 associated arthritis. Here you can see the sacral joint involvement and spine involvement when they grow older. They also have large joints. Small joints are not get involved here, and they have very specific feature called enthesitis. Enthesitis means the attachment of tendons, the inflammation at the attachment of the tendons. So this is what tendo-Achilles or enthesitis. So juvenile idiopathic arthritis. So this is a picture of young girl who has got right knee monoarthritis, oligoarticular. This is what you see them when they have the uveitis. You can see this irregular people due to synechiae. You need a ophthalmoscope examination. This is symmetrical polyarthritis of small joints in a child with polyarticular JA. So this is your enthesitis, inflammation at the attachment of tendons. This is psoriatic arthritis, arthritis plus psoriasis. You can have nail pitting. We have something called digital sausaging. This is psoriatic skin lesions. This is your dactylitis, which is commonly seen in psoriasis. Psoriasis also can have HLA-B27 positive. So why I'm telling all those things is when you order the test, you should order according to the clinical pattern. So if you have oligoarticular JA, you should order only ANA. If you have polyarticular disease, you should order only rheumatoid factor. If you have psoriatic arthritis or enthesitis related arthritis, you should order HLA-B27. You should not order everything for everybody. Based on your clinical diagnosis, you order the test because test is going to support, it is not for diagnosis. Okay, so far we talked about infections, we talked about post-viral, then we talked about inflammatory. Now we are going to talk about non-inflammatory causes of joint pain. So here is a 10-year-old boy. He has got 1 year history of left-sided limp, complaining of pain involving the left thigh and knee. He denies any fever preceding the illness or trauma. On examination, he was afebrile. He walks with a painful hip, obese. He has got an examination. He has got decreased movement on the left hip. Left knee is normal. His inflammatory parameters were normal. So this child we should suspect, 10-year-old child, we should suspect slipped capital femoral epiphysis or Perthes disease. These are the two non-inflammatory conditions, especially orthopedic conditions, which can land up in your general pediatric OPD. So slipped capital epiphysis is common in 10 to 14 years. It is usually associated with the endocrine disorders like hyperthyroidism or growth hormone deficiency. X-ray is for diagnosis. So this is the X-ray of the child who presented with left hip pain. So we have to draw a line, very simple line, something called Klein line. So you draw a line on the outer aspect of the neck of the femur. Normally we should see that's femoral condyle. The femoral epiphysis should be below the line, but here you can see the femoral epiphysis is below the line. That is suggestive of slipped capital femoral epiphysis. If you take a frog leg view, this is the normal AP view. This is a frog leg view. So if you see here, it is like your cone, ice cream cone. The ice cream from the cone is just falling down. Your head of the femur is just falling down from the cone. And it's usually a surgical treatment. You have to refer to the orthopedician. They will fix it with the nailing. And Perthes disease is nothing called, otherwise called avascular necrosis of the femoral head. X-ray, if it is grade 3 or grade 4, you will be able to see in X-ray, but MRI is the gold standard. Remember that Perthes disease can happen due to trauma, developmental or inflammatory conditions, which is especially with lupus, or treatment with long-standing steroids, or coagulation abnormalities also. Because you know that the blood supply to the head of the femur is gone. Again, surgical treatment, they will do either osteotomy, if it is very severe, so they will do the replacement. So from our pediatrics, what we have to do is, we have to advise less weight bearing or no weight bearing and refer to the orthopedician for surgical management. Growing pains, I don't need to tell for all the pediatricians, we are all well versed with growing pain. It's a benign, intermittent, non-articular pain, cause we don't know, and presence from 3 to 10 years of age also, especially happens in the night. But remember that malignancy, they will sick all the time. This morning, the child will be asymptomatic and have no functional limitations, will be running. Physical examination will never associate with warmth, swelling, tenderness, or fever. Family history may be there, so only parental reassurance. We can give some paracetamol, mild analgesics. Hypermobility is another one which they come. We always call double jointed children. So they have a lot of, sometimes they come with pain, only with arthralgia. When you examine, they will have hypermobile joints, especially you can see here the knee hyperextension. This is the fingers hyperextension. Girls are more common, family history may be there. Remember that in the hypermobile joint syndrome, we have something called Beighton scoring system. So your little finger goes beyond 90 degrees, we're able to touch the thumb and the volar aspect, and the knee extends 10 degree and the elbow extends again more than 10 degree. and he or she should be able to touch the floor without bending the knee, both the palms down. So each side 1, 1, 1, 1. So 8 plus 1, 9. If anybody has got more than 6 points out of 10, they are called hypermobility. Remember that any child with hypermobility, always look for loose skin. Okay, and easy bruisability, you think of Ehlers-Danlos syndrome. Other syndromes associated with hypermobility are Marfan's, homocystinuria, Down syndrome, Vellore syndrome, and cutis laxa. So don't miss this hypermobility syndrome because they are important for diagnosis and for prognosis to reduce the morbidity and mortality. Okay, so we'll come to some case scenario which are the mimics of arthritis. So here I'm going to show you, this is 2 children. They came to me, 2 siblings, 9 years old girl and 7 years old girl, both born to 3rd degree consanguineous parents. They are developmentally normal for age, and a history of bilateral enlargement and stiffening of interphalangeal joint and elbow joint since 4 years of age. So this is the hands of both the children. You can see there is swelling of all the interphalangeal joints. You can see on the toes also it is swollen. You can see the elbow swelling of both the hands of both the children. And you can see also some scoliosis. This is a girl, this is a boy. So this is both the children. So our diagnosis is something called progressive pseudo-rheumatoid arthropathy. So it is not arthritis, it's arthropathy of children. So we have to take x-rays. This x-ray, the first x-ray, the hand x-ray is a normal x-ray. Here you can see this metafacial widening here. So it is one of the spondyloepiphyseal dysplasia. And you can see here there is no, the head of the vestibular cavity is straight, and you also see some speckles on the femoral head. The spine will show what you see in your mucopolysaccharidosis, something called beaking. So the beaking, all the beaking of the vertebra is not mucopolysaccharidosis. We should consider pseudo-rheumatoid arthropathy of children. So it's a rare skeletal dysplasia. It mimics like JA. It is a spondyloepiphyseal dysplasia. It is autosomal recessive. That's why it runs in the consanguineous parents. And the WISC and something called WISP3 gene mutation. So this type of children, very sad. There is no specific treatment. So no point in putting these children on inflammatory drugs and disease modifying agents. So this children has to go for physiotherapy, and is basically an orthopedic intervention if there is going for more contractures. Not a very good disease to have. We cannot revert it because it's a genetic cause. So to summarize, how do you approach, or what are things you see? It's the same 5 questions. If you remember these 5 questions, you are able to make a decent diagnosis in an OPD, and you can investigate, or if you want to refer, you can refer to the appropriate person. So arthralgia or arthritis, articular or periarticular, is it inflammatory or non-inflammatory? What is the pattern of joint involvement? Based on that, we diagnose, and associated symptoms and signs are very, very important, especially in malignancy and non-inflammatory conditions. The symptoms and signs are very, very important to make a proper diagnosis in the outpatient clinic. Okay, so the next part of the talk is going to be on pyrexia of unknown origin. So this is actually the pediatrician's nightmare. So this is actually makes the pediatricians anxious, parents anxious, especially when the child comes with fever. I'm just going to show you a story of a 7-year-old girl who is one of my doctor colleague in orthopedics daughter. She's 7 years old. She had fever for 11 days. All the investigations were normal. So no nasal discharge, dysuria, nothing to suggest apart from fever. She has some headache at the height of the fever. Whenever the fever goes away, the headache goes down. No past history of anything of TB. When we look, child is well looking, has got some allergic shyness because he has got recurrent upper respiratory infection, no pallor, icterus, no lymph nodes, no meningeal irritation, no tachypnea, heart sounds are normal, no liver, spleen. And we have done tests multiple times. Because the fever is persisting, we started with cefotaxime, 3 days, culture negative, repeat culture. Again, culture negative, the child was started on piptas, amikacin. No pathogens were identified, blood culture negative, chest X-ray negative, ultrasound negative, echo negative. So all the cultures are negative, but only everyday fever is coming. Nothing is suggestive of any other particular disease to know what is the cause for fever. So as you know, that pediatric is an orthopedician and is my friend. So he wanted infectious disease consult. The child is admitted to a pediatric ward, and he wants a ID person's consult. Okay, so all the scrub routinely, whatever you do for 10 days, fever is negative. Vidal, Wheel Felix, dengue, scrub, everything is negative. Chest X-ray, mild bronchovesicular markings. So fever without a focus, because he wants an ID consult, we call the ID expert in our hospital. So ID experts, this is what exactly the ID expert writes in the consult sheet. So what at the next blood draw, send brucella IgM, leptospira, spotted fever IgM, stool occult blood as screening for inflammatory bowel disease and stool parasite. If CT brain has not covered the frontal and maxillary sinus, please do X-ray PNS and get ENA opinion. Lumbar puncture with the whole set of things for viral, TB, everything. Bone marrow to be done. There is aspirate, biopsy, routine, fungal, gastric aspirate for AFP, midget AFP, and gene expect AFP. And they wrote in the chart, if all these things are negative and the fever persisted, please consider workup for autoimmune disease. This is what exactly they wrote. So it's actually like this. So whenever a fever child comes without focus, if you call the specialist, they will write everything in their specialty. So if you call the oncologist to kindly rule out oncological cause, they will write, please do lumbar, please do bone marrow examination. So that's what they always write. But somebody has to see the child as a whole and see what we can do. That whole person to say that this is an elephant is a pediatrician who has to look as a child as a whole. So more than specialist opinion, I think the general pediatricians have a great role in managing a children with PEO. So this is a nice table. If you look into the cause of PEO, there's a huge starting from infection, non-infection, malignancy, rheumatological condition. And you see 15 to 20% of the time are rheumatological conditions. So whenever you come into the rheumatological conditions in a PEO child, so what do you consider in a rheumatic diseases? If somebody has come with less than 7 days of duration, you should suspect Kawasaki disease, which is very, very important when children present with 7 days of fever. We'll come into details. And there is a rare periodic fever syndromes, which will come with a recurrent fever, especially they all are usually short-lived fever. When somebody has got prolonged fever, more than 7 days fever, you think of systemic JA, or you think of vasculitis, or sometimes SLE initially can present with fever. So these are the two things we should consider when as a rheumatological cause when somebody comes with PEO. And we all know well versed with Kawasaki disease. Okay, so we all well know that Kawasaki disease, complete and incomplete, and complete Kawasaki disease 5 criteria. Incomplete means less than 4 clinical features of KD. Fever should be more than 5 days, but along with that 4. So we have very nice guidelines. How do you manage? So if somebody has got less than 4, then you look for ESR and CRP. And if there is ESR and CRP is high, and if there is a positive echocardiography which involves the coronary arteries, you straight away treat like Kawasaki disease. Or if there is echo is normal, again you go for these 6 things. If 3 or more, definitely it is incomplete Kawasaki disease, especially anemia for age, platelets more than 4.5 lakhs, albumin less than 3, SGPT levels are high, urine WBC is high, and white cell counts are more than 15,000. If 3 of these things are there, you should suspect incomplete Kawasaki disease. So this is a classical, we all know that, eye congestion, cervical lymph node, which can be more than 1.5, unilateral or bilateral, your classical strawberry tongue, and the rash can be anything. And you see the peripheral changes of the dorsum of the hand and the dorsum of the feet. And in the subacute phase, especially on the 2nd week of the illness, you see this typical peeling, which starts from the fingertips and then goes up. So this is what usually happens on the subacute phase. So this subungual peeling does not come under the criteria for diagnosing Kawasaki disease. So when you suspect juvenile idiopathic arthritis, this is very classical. The children will be very sick looking during the episode of fever, but they are very well when they are afebrile. Leukemic children will be sick all the time. Infectious children will be sick all the time. And typical fever pattern, which you see once or twice a day spike, which comes back to normal. The classical rash, which comes along with fever, and they can have polyarthritis, and they can have large and small joint arthritis. Very important thing. So yeah, we have a criteria for systemic JA. I told you in all the JA, we should have at least 6 weeks of symptoms, but here only 2 weeks are enough. They should have the classical evanescent rash, that means comes with fever and goes away with fever. They can have lymph node, hepatosplenomegaly, and serositis, especially pericardial effusion, pleural effusion. And remember that it's a diagnosis of exclusion. When somebody presents like this, TB can be a diagnosis, HIV can be a diagnosis, malignancy can be a diagnosis. Kindly remember, you have to rule out all the cause of other causes before you make a diagnosis of systemic JA unless they have classical fever, classical rash, because once you start steroids for them as diagnosing systemic JA, we will mask the malignancy. Clue towards SLE, again SLE is very easy to diagnose, especially adolescent girls, multi-system involvement. You can see these are the 3 of patients where you see this classical malar rash, there's a rash on the malar area, on the forehead, classical oral ulcer, painless oral ulcers on the palate. So they are painless. So children will not say I have pain, and they can have Raynaud's phenomenon also. This is what we classically teach our postgraduates. MD, so brain, malar rash, discard rash, serositis, arthritis, photosensitivity, blood, renal, ANA, immunological, and neurological. So anybody, especially adolescent girls who present with prolonged fever, fatigue, malar rash, oral ulcers, we should suspect lupus. Another one is dermatomyositis. Again, here they have classical muscle weakness, classical heliotrope rash. This is the Gotran's papules over the knuckles. This is Groton sign over the knees. You can see the eyelids are closed. You can see this purplish rash over the eyelids. That is your heliotrope rash. This is something called V sign. If you see the nails, they will see something called nail fold capillary changes. Basically, they are the vasculitis of the capillaries. You can see the bushy capillaries, dilated capillaries, absent capillaries. All those things can be seen in juvenile dermatomyositis. So this is your classical Gotton spine. So sometimes JDM can not treated properly. They can have something called calcinosis cutis. This is some of the pictures of our patients who had calcinosis. That's a calcium deposits on the subcutaneous plane. They will have discharge, one of the dreadful complication of dermatomyositis. So when you come to the vasculitis, again, this is a classification of vasculitis which comes from large vessel, medium vessel, small vessel. Vasculitis diagnosed very easy because in children, only Takayasu arthritis, there is a large vessel vasculitis. Medium vessel vasculitis, we have both polyarthritis nodosa and Kawasaki disease. In the small vessel vasculitis, we have only the very common is your Henoch-Schwann purpura, or the other name is nowadays we have to call as IgA vasculitis. Your ANCA-associated vasculitis are very rare in children. So children very common, large vessel Takayasu, medium vessel is Kawasaki, polyarthritis nodosa a few patients, and HSP is a common as small vessel vasculitis. So when will you suspect vasculitis? Somebody presents prolonged fever, they have weight loss, serositis, hypertension, especially in polyarthritis nodosa and Takayasu arthritis, rash, purpura, nodules, and livedo reticularis. Purpura means small vessel vasculitis. Nodules and livedo reticularis means medium vessel vasculitis. Renal involvement again can be there in ANCA-associated vasculitis or HSP. They can present with hematuria, renal failure. Arthritis and arthralgia common. We can see in Takayasu arthritis, even Kawasaki disease, we can see arthritis, and in HSP. Myositis, myalgia can be seen in polyarthritis nodosa. Absent pulse, very important for a child who presents with prolonged fever. Absent pulse indicates Takayasu arthritis. Pulmonary infiltrates or hemorrhage can be seen in vaginous dermatomatosis and associated vasculitis. So these are the skin lesions. Somebody comes with gangrene, always suspect medium vessel vasculitis. Somebody comes with purpura, it is small vessel vasculitis. So this is again, this is like a plaque-like lesion which is seen in polyarthritis nodosa. Chronic non-healing ulcers, suspect medium vessel vasculitis, especially polyarthritis nodosa. Typical punched out lesions, ulcers of non-healing type. Gangrene, as I already told you, you always think of medium vessel vasculitis, especially the cutaneous, systemic pan. Henoch-Schwann purpura, we all know that pediatricians, a typical palpable purpuric rash, they also can have dorsum of the hand swelling, like your Kawasaki disease. Sometimes they can present acute scrotum. If you do biopsy, you will see leukocytoclastic vasculitis and classical IgA deposit. They can present with intussusception, and if you do ultrasound, you will see the typical target sign. They can also have mucosal erosions leading to GI bleed, secondary to vasculitis. So HSP, they have a triad, diffuse abdominal pain, any biopsy showing predominant IgA deposition, arthritis or arthralgia. Remember that the mandatory, they should develop palpable purpura and any one of the 4 features. They can have abdominal pain. If you have biopsy, they can have hematuria and proteinuria, arthritis and arthralgia. So to summarize, to fever and rash in our OPD. So as for the temperature pattern, how was the child between the fever? Does the child have any fever, any rash, muscle weakness, hair loss, oral ulcers? Suspecting SLE and dermatomyositis. Family history is very important because all the autoimmune disease runs in the family. If there is a rash, what type of rash? Where is the location of the rash? Look for the muscle weakness, uveitis, arthritis, hypertension, very, very important. Lymphadenopathy, hepatosplenomegaly, serositis. So again, this is all part of systemic JA. Extra-articular manifestations are very, very important to make a clinical diagnosis. The pattern recognition is again very, very important. There is a group of rare disease, something called autoinflammatory syndrome. We are started seeing in our clinic also. But remember that these all are very rare. If you don't diagnose autoinflammatory syndrome, that's fine in the clinical, in your busy OPD. But we should not miss the common septic arthritis. We should not miss HSP, Kawasaki disease and all. So if somebody comes with recurrent fever, characteristic rash, they have granulomatous rash, pustulosis, libido rash, erysipelas like rash, serositis, pericarditis, especially something called FMF, arthritis, after ulcers, Behçet syndrome, sterile bone lesions, and laboratory evidence of persistent ESR and CRP high, or again, whenever there is a periodically, if the symptoms comes, the inflammatory markers will go high. This is a table to show you there are a lot of conditions available. When you suspect, you can always go back. It's very difficult to keep in your mind all the autoinflammatory syndromes. It is available in all the standard textbooks. Even the Nelson gives a nice table about the autoinflammatory syndromes. Based on skin rash, arthritis, bone involvement, CNS inflammation, lymph node, we can make a diagnosis. So coming to the third part of my talk is on laboratory clues. So if somebody has got neutrophilic leukocytosis, you suspect systemic JA, especially they exactly look like infection. Okay, high white cell count, high neutrophil count. But remember, if they have thrombocytopenia, you should suspect infection. If there is thrombocytosis in the child, always suspect rheumatic disease. It could be vasculitis, it could be Kawasaki disease, it could be systemic JA. Sometimes you have to wait for the the disease pattern to evolve. Leukopenia, especially in rheumatology, you think of lupus or macrophage activation syndrome. Thrombocytopenia again in lupus and macrophage activation syndrome. ESR and CRP. Remember that there are a lot of inflammatory markers available. C-reactive protein, serum amyloid, haptoglobulin, fibrinogen. Remember that albumin is a negative inflammatory marker. That's why in Kawasaki disease, when you have severe inflammation, your albumin may be very, very low. And ferritin, another very, very important inflammatory marker. If anything more than 500, either can be infection or inflammation, but if anything more than 10,000, it is macrophage activation syndrome or HLH, otherwise unless proved. If they have anemia, leukopenia, lymphopenia, thrombocytopenia, increased ESR, increased LDH, uric acid, you suspect malignancy. Okay, CRP is more useful than ESR because ESR is affected by various things, like even anemia will cause elevated ESR, and the CRP goes up very fast during the infection or inflammation and comes down fast. So 3 important rheumatological tests we should be in practice, we should use it very cautionly. One is the ASO titer. Remember that in India, most of us will have high ASO titer. And what does ASO titer means? The child has got either recent or prior streptococcal infection. It should be, or they have scarlet fever if they have symptoms of scarlet fever, post-streptococcal glomerulonephritis, or acute rheumatic fever. Somebody has got a joint pain, don't do ASO unless you see arthritis to diagnose either rheumatic fever or post-streptococcal. For routine joint pain here and there, don't do ASO. And we all know that it arises after 3 to 4 weeks after the infection, and it can stay high for 1 year. And don't put some child on penicillin because of persistent elevated ASO. If the child is symptomatic with tonsillitis, you treat. Otherwise, don't give much importance to the ASO. And ASO positivity does not make a child to have a long-term prophylaxis with penicillin. It has to be given only for acute rheumatic fever after that. Rheumatoid factor, again, rheumatoid factor negative does not rule out juvenile idiopathic arthritis. As I told you, rheumatoid factor is to categorize the juvenile idiopathic arthritis, especially when they present with adolescent girls who present with polyarthritis. Then you do rheumatoid factor. Rheumatoid factor is again for diagnosis. You have to do it twice, 12 weeks apart. That is for the criteria for diagnosis, for classification criteria, not for diagnosis. If the rheumatoid factor is present, it suggests poor prognosis. Those type of children will go for aggressive erosive arthritis. And again, once rheumatoid factor is positive, it cannot be need to be repeated every time to see that levels to assess the disease activity. And again, I'm telling you, absence of rheumatoid factor does not exclude the diagnosis of JA. I told you only 5% of the JA is rheumatoid factor positive. So you have to order rheumatoid factor for classical pattern recognition of adolescent girl with symmetrical polyarthritis of large and small joints with early morning stiffness. ANA is another one very misused test. It supports or increases the likelihood of connective tissue disease. Mere presence of ANA does not make a diagnosis of SLE because in SLE, ANA can present in up to 5% in children. It can go up to 20% in the adults. When the age increases, the ANA titer increases. Again, it does not correlate with the disease activity. So no need to do ANA every time when you see a child with SLE. It has got very high sensitivity. You can rule out SLE. If you suspect SLE, if the ANA comes as negative, almost 95 to 99% it is not SLE. Very rarely we can have something called ANA negative SLE. But remember that all ANA positive is not SLE. So it is not good for making a diagnosis of SLE. It is only to screen a child for SLE. And nowadays, in all the private hospitals, there are a lot of panel and packages available. Like you can go to a travel package, you can go to Thailand, Singapore for package. So like that, arthritis panel, SLE package, vasculitis panel, myositis panel. There are a lot of panels available. Try not to do those things because I tell you, arthritis panel will include ANA, rheumatoid factor, and HLA-B27. ESR CRP counts, creatinine, liver function test. This is usually the arthritis panel content. So I already told you, don't do in a young child, girl child who has got oligoarticular juvenile idiopathic arthritis, no point in doing rheumatoid factor and HLA-B27. You should order only ANA. If it's an adolescent boy who comes with the hip pain, who has got classical enthesitis, you do HLA-B27. Same thing SLE, you start with ANA. Unless the child has got florid SLE features, we can order the panel where all the things will come. But don't order the panel unnecessarily. Vasculitis, I told you, large vessel, medium vessel, small vessel. Only for the small vessel, we have ANCAS. If it's a Takayama arthritis, no point in doing ANA, no point in doing ANCAS for that child. Again, polyarthritis nodes are no point in doing those things. Okay, so panel you select according to your clinical scenario. So ordering a panel test before making a clinical diagnosis is agreeing for your marriage without seeing your life partner. So don't do so. Sometimes reports comes positive. Some child has come with 10 days of fever. You do SLE. SLE has come as positive. What will you do with the result? Child is now well. So don't do, make a clinical diagnosis and order the test accordingly. So because if you do like that without seeing the clinical diagnosis order, it can happen. You may pick a diagnosis. Sometimes this also can happen. Beware. So don't order any panel or packages in rheumatic diseases. So I want to show you about the last thing. If somebody said it's a chronic disease, incurable disease, we agree that all the autoimmune diseases are chronic and incurable, but we can make a change in life of every child who was diagnosed to have rheumatic diseases. So here is a child with SLE. His mother has died because of SLE. This child is around 7-8 years when she came to me first. She came with class 4 lupus nephritis. This is almost after 2 years of treatment. She is very well. You can see that you cannot even imagine the same child. So this is a child when she became 17 years. She was transferred to the adult rheumatology for follow-up. So they all do very well. So this is another one SLE. This is from my native place. So this is a child who again with class 4 lupus nephritis and CNS lupus. This is almost after 1 year of treatment with steroids, mycophenolate. And this child also is now just going to go to the college. So this is another girl with SLE. You can see the classical sparse alopecia, the rash on the malar area. She also had class 4 lupus nephritis and autoimmune hemolytic anemia. So here is the child. Here you can see almost after 6 months, the child is absolutely fine. So another one small child with something called monogenic lupus, which is not very common. This is after treatment with steroids and azathioprine. So this is a child with neonatal lupus. You can see the typical annular rash and the raccoon eyes. Mother is positive with SLE. And this is almost after 3 months with the topical steroid. Luckily, this child did not have any heart block. So this is a child after that. So this is one of my SLE patients. When I was doing my PG, she was seen by my boss, Dr. Debesh's Danda, and I started to follow the child. So now she has got married. She got a first child, and she came to show me the child. Luckily, the child did not have any features of neonatal lupus. This is the first child. Now she has got the second child. So she is living a normal life with the children happily. So what Corona has done to pediatric rheumatology? In the pre-corona days, rheumatology was not given much importance. Even the rheumatological drugs were not given importance. Okay, especially hydroxychloroquine, Actemra, which is what tocilizumab, and dexamethasone. Dexamethasone, I know everybody uses, but nobody gave importance to rheumatological drugs. After this corona pandemic came, and especially after our previous US president says, I'm also taking a CQ, and he spoke to our prime minister for hydroxychloroquine, okay, for the friendship and the leadership, and our prime minister sent hydroxychloroquine to US for the people. And now post corona days, it's not post corona days, now everybody asks about hydroxychloroquine, everybody talks about tocilizumab. I think corona has brought rheumatology and rheumatology drugs to the limelight. So with this, I will stop it here, and I'm very happy to take any questions. Thank you very much for this opportunity to talk to you in this digital platform. Thank you.
Thank you, Sathish. Thank you for the wonderful deliberation of the topic per se. We have learned many new things. Your systematic approach in dealing with the case of rheumatological problems is definitely going to change our style of dealing with these cases. So thank you for the wonderful talk. And now let us see whether the participants has raised any question. How many cases of MIS-C so far you have seen in our facility, Sathish?
So in the last 2 months, we have almost 15 children in our ICU. We have seen. Nowadays, actually, these last 2 weeks are getting more. That's what we are expecting, actually, because the adults, the disease has come down. So we always see more missed cases. 2 to 4 weeks after the adult pandemic, the numbers come down. So we are expecting more cases to come. Currently in the ward, I have 2 children with MIS-C, and most of the children are in our ICU, and a lot of children presents with Kawasaki-like illness. Okay, the last child I discharged, actually one child yesterday, who came with fever, rash. Now I have one more child was referred to me from Coimbatore yesterday, suspecting MIS-C, because they discussed with me, they are given IVIG, and they are given steroids, but the fever was not coming down. This child personally is an older child, 6 years old child with fever, again like an incomplete Kawasaki disease. So this child has got a rash, and this child has got some eye symptoms. And the echo is also showing mild coronary artery dilatation. So we have her RT-PCR is negative, but antibodies are awaited. Antibodies done in Coimbatore was positive. Antibody done in Coimbatore was positive. And we have one more children last week. This child was admitted at the month of September end, on October 1st week. Parents are positive. This child is also positive. And that time child didn't have any symptoms. Because the parents positive, child is positive, we admitted for 7 days as per our protocol. And the child was discharged. And 1 month the child was very well. And now the child came with fever, Kawasaki-like illness, shock, and myocarditis. And this time again we gave steroids, IVIG. The child got better actually. So we are seeing cases. It's only the time we have to recognize more actually.
Okay. So even in Savagasi also we have seen quite a few number of MIS-C cases. And my doubt is, can we stop aspirin after 6 weeks?
So the aspirin is so the guidelines for MIS-C treatment says that if they come with Kawasaki-like illness and if they have a cardiac involvement, then you give aspirin. Suppose if they come with Kawasaki-like illness and they don't have a cardiac involvement, we don't need to give aspirin. Okay, we just give steroids. IVIG you give steroids for 7 to 10 days and stop. So we don't need to give aspirin if the cardiac involvement is not there. If there is a cardiac involvement, either any form of cardiac involvement, if the Z score is more than 2.5 or anything, any aneurysm, small, large, medium, any aneurysms, then you have to give aspirin. Otherwise, because anyway we are giving steroids. Anyway, we are giving steroids during the acute phase. Steroids is a potent anti-inflammatory. So we no need to give actually aspirin if there is no cardiac involvement. So no need to give high dose aspirin. Only the low dose aspirin, 3 to 5 milligram. If they have a cardiac involvement, you give them for 4 to 6 weeks. Otherwise, no need to give that also.
Okay. So only IVIG and steroids, these two are enough.
Yes, IVIG 2 grams per kilogram as per Kawasaki disease protocol. And there is no clear protocol for giving anticoagulation because we never see any children with any thrombosis. But anybody who goes to ICU on cardiogenic shock or hypotensive shock, we are giving initially heparin. When they come out, we make it to Clexane. But when they go home after 7 to 10 days, we usually stop them. So we don't send them anybody on warfarin. So most of the patients are like almost everybody is doing very well. We are not seeing anybody typically going into cytokine storm syndrome with pancytopenia, like where to give, we have to give tocilizumab. Shock, yes. Kawasaki-like illness, yes. But typically what is described the cytokine storm syndrome, we have not seen them in the last 2 months in our institute. Going like a HLH, pancytopenia, hyperferritinemia, again with the liver dysfunction, we are not seeing.
Okay. Can you elaborate a little more about reactive arthritis post-viable?
Yes. So reactive arthritis, again, as I told, they can present following either throat infection, urinary infection, diarrhea. Sometimes they present only with fever also. So they all come with reactive arthritis. They all come with small joint and large joint pain and swelling. So what usually we do is we put them on, I don't give steroids for them on the day one. We put them only on naproxen or indomethacin. Both works very well. So reactive arthritis most of the time settle with 4 to 6 weeks of naproxen or indomethacin has to be given. Don't give 1 week, 2 weeks and stop. It will come back. Any rheumatic diseases, we have to give anti-inflammatory for at least 4 to 6 weeks. They all do very well, especially in HSP also. I have seen so many times. Diagnosis correct, started on NSAIDs or sometimes steroids. They give it for a week and they stop it. What happens after 1 week? The disease comes back. Then they refer to me saying that the child is not responding. Ideally, in any rheumatic disease, we know it is chronic disease. To put the immune system down, we have to give anti-inflammatory for 4 to 6 weeks. What I do is we start on naproxen or indomethacin. We give it for 4 weeks. Initially, ESR, CRP will be very high, and when they come back, I will repeat the ESR and CRP. The ESR and CRP are normalized, and the patient is very well. I stop the naproxen. Suppose ESR, CRP is still higher. I don't start naproxen because I know there is a chance of coming back. So I continue for another 2 to 3 weeks. And NSAIDs are very safe in children. As we all know that children does not have any comorbid factors. So giving NSAIDs, worrying about whether the renal toxicity, nothing has happened so far.
Okay. Now the following questions have come up. Have you used tocilizumab for MIS-C so far?
So that's why I was just telling them. So far we are not used. So it is a third line drug. So first line is IVIG. Second line, first IVIG plus steroids. So most of our children settle with that. Tocilizumab is a third line. If somebody were given steroids 30 milligram per kg for 3 days, then you give 2 milligram per kilogram. With that also steroids is persisting. So yesterday I told you the child was referred to me from Coimbatore. Okay, one of our close friends. They diagnosed this child of PIMS TS with incomplete Kawasaki disease. Antibody test is positive there. RT-PCR is negative. So this child, they given IVIG. They called me on the day one. I told, okay, give IVIG steroids. Steroids were given. Still the fever is not going down. And the ESR CRP is slightly high. So they referred, he said that, sir, and this child's echo also showed some amount of dilatation. So It's not very big, mild dilatation. So the question was whether to give tocilizumab or infliximab. And the parents are a little anxious there and all. They said, okay, go to the higher center. They came here. So I admitted the child. I continued the steroids. I don't know, luckily or unluckily, this child does not have fever after admission for the last almost 36 hours. There is no fever. So if this child would have got fever, I would have given infliximab. See, remember infliximab, TNF alpha blocker, because this child had coronary artery involvement. Suppose this child does not have a coronary involvement, and if the fever is persisting, I would have given tocilizumab. But so far, we have not given tocilizumab for any children in our cohort with Miss C.
Okay. And another question is there any cutoff level for ASO titer to diagnose acute rheumatic fever?
Okay, so the cutoff depends on the lab which you are doing. I remember that the olden days we used something called 333 Todd units.
Yes.
Olden days, the cutoff is 333 Todd units, which Dr. Venkatanal taught me when I was doing my MBBS in Tirunelveli Medical College. Nowadays, nobody uses Todd units. Nowadays, most of the labs is done by something called nephrometry. That's the one they do. They give in international units per ml. In our hospital, the cutoff is 300 international units per ml. So we have to check with your lab what method they are doing and what is their cutoff in their particular lab. And the four-fold rise, we never checked. Okay, and I don't think we have checked for four-fold rise to see after 4 weeks to see whether the ASO is going high or not. Okay, unless it is clinically, what are you dealing is important than the ASO titer levels.
Okay. If there are no more questions, then we can wind up the session. Thank you, Sathish. Thank you, Ba. You have lived up the reputation for.
Thank you.
Thank you
for
nice.
Sathish speech ரொம்ப பிடிச்சது வந்து அந்த நாட் ஆர்டர் panel, investigation panel. Not order marriage without seeing the life partner. Very good. It's very nice. Okay.
Thank you, sir. Thank you, sir.
Right. Yes, Sathish. என்ன மறந்துச்சா உங்களுக்கு?
Formal Shanmugam. Let us say formal vote of thanks, Shanmugam. Now, before asking our IMA secretary, Dr. Shanmugarajan, to propose the vote of thanks, my sincere thanks to Dr. Nikhil from Virudhunagar, who has been the anchor for this StreamYard and YouTube presentation. Thank you, Nikhil. And over to Dr. Shanmugarajan for his vote of thanks.
Okay. All our IMA members and Virudhunagar Pediatric Forum members and all the other pediatric colleagues from all over state, I thanks all of you for seeing this good CME delivered by my junior Dr. Sathish. Thank you, Sathish, for your wonderful. Thank you, Sathish.
Thank you, sir.
Thank you.
Nikhil,
Yes,
Nikhil, live broadcast.
Nikhil?
Can you stop the live broadcast, please, Nikhil? Okay, we can exit and we can chat in the WhatsApp
Sure.
video call, Shanmugam and Sathish.
Yeah,
okay.
Thank you.
Okay,
thank you. Thank you, sir.
We can wind up. Thank you, Sathish.
Okay. Thank you, Sathish. Thank you.